So also I should thank Dr. Jawahar for such a short notice he was willing to present.
Thank you, sir. It's an opportunity for me to present this interesting case. Thank you for the opportunity given.
Thank you. Haley, are we live?
Yes, sir, we are.
Okay. Fine.
Dr. Aishwarya.
Yes, sir.
Yes,
Just wait, Jawahar sir, sir will introduce all of you.
Okay.
Sudhir Shah sir will introduce all of you.
Do you want to do this time, Dr. Lakshmi?
Sir?
Would you
Yes,
want
sir.
to introduce your department?
No, no issues, sir. Sir, it's a prestige and honor that you introduce them, sir.
You know them better.
I know them, sir, but still,
All right.
sir, the words from a great man is more prestigious, sir.
You are a very humble man. Actually, we all respect you, your knowledge, your humility, your kindness and
Thank you, sir.
compassion.
Oh, sir, all your blessings. Sir. Thank you so much, sir.
You are a unique, priceless achievement of IAN itself. IAN is proud of you.
Thank you, sir. Thank you, sir. Thank you, sir.
Ellie, please give me a clue when we need to start.
Yes, sir. 1 minute more and then we can.
People are joining now. I'm seeing
Yeah,
that
yeah,
count.
people are joining, still joining.
Then wait for 2 minutes.
Yes, sir.
Okay,
Okay.
sir. So we can start.
Yes,
Manoj sir.
please start.
Good evening, ladies and gentlemen. Let me begin by wishing each one of you belated Happy Diwali and a very, very grand New Year. Welcome to Secrets of Neurology, a knowledge feast for all oncologists, episode 28. Probably the largest running academic neurology web series in the Asia Pacific countries. And a warm welcome to the team of Madras Medical College and RGGH Chennai. This has been possible because of our course director, Professor Dr. Sudhir Shah sir, and Dr. Lakshmi Narasimhan sir, who has provided all the possible concepts and academic support for this knowledge feast. As we would conclude by 9:30, plus minus here and there. This happens on every Friday, last Friday of every month. An honor and privilege for me to briefly introduce Professor Dr. Sudhir Shah sir. We know him very, very well. Professor and Head of Department, NHLMMC, NSBPI, MSR, Ahmedabad. And sir is also Director of Neuroscience at prestigious Sterling Hospital, Ahmedabad. Recipient of various accolades and awards because of his work in the field of neurology, service to mankind and patients at large. Dr. Sudhir Shah sir was conferred the prestigious Padam Shri by Government of India. Sir is also recipient of prestigious BC Roy Award and UNO Award. Dr. Shah's interest is into stroke, neurodegenerative disease, and epilepsy. Our second director, equally competent, Professor Dr. Lakshmi Narasimhan sir, Director and Professor, Institute of Neurology at prestigious Madras Medical College, Chennai. Recipient of Paltussi Award from AN, A.B. Baker's Award, Global Elsevier Award, and huge contribution to the field of neurology, not just in the country, but at a global platform. May I request both our program directors, sirs, to take it forward from here.
Thank you, Dr. Manoj, for that kind words of introduction. First of all, let me wish you all a wonderful, prosperous, happy, healthy, and peaceful New Year to each and every person here, including the presenters, the delegates, and team in task, and of course, my co-course director, Professor Lakshmi Narasimhan. As you know, this is one of the longest lasting webinar series on the teachings of neurology titled as Secrets of Neurology. And this is 28th episode. So we have finished 2 years and 4 months by now. Thanks to the unflinching efforts of Team Intas headed by Mr. Chadda and Dr. Manoj and Dr. Haley and others. Thank you very much. More than anyone, I have to appreciate all the delegates for the support, interest, and participation they have shown all these months. And we are getting overwhelming responses from all over country and many neighboring and distant countries, including USA, Canada, UK, Spain, Netherlands, and Thailand, Sri Lanka, Pakistan, and other countries. So it's a matter of great pleasure and in fact a bit of honor that we have such a wonderful response. I want to thank my colleague, Dr. Lakshmi, Professor Dr. Lakshmi Narasimhan. You know, he is a very kind, pleasant, and humble personality, highly knowledgeable, and he is the backbone of the whole webinar series because his efforts are untiring efforts. Even today, it is his team from Madras Medical College who is presenting today's case, and the name of the case is Storm in Winter. I'm sure it would have some unusual kind of case, or the title must have some meaning. I really want to see it getting unfolded. May I have the first slide, please? The consistency, the quality, and the level of teaching that this series has carried, that many people have asked for the archives of the previous episodes, and I am very happy to tell that at request it is available from Team Intas. Dr. Heli Gadani can help you if you wish to retrieve any of the previous episodes. With that, I would like to introduce Dr. Aishwarya G. Kumar, the final year resident of DM Neurology from Department of Neurology, Madras Medical College and RGGGH, Chennai. She
Thank
is
you, sir.
going to present the case, and I'm sure it will be a very interesting case. This would be further taken with regards to localization and discussion by Professor B. Krishna Kumar. He is an assistant professor, Department of Neurology, same college and institute, and he is MD DM Neurology. Very down to the earth personality, and I'm sure you will enjoy
Thank you, sir.
the way he discusses the case and dissects it properly. And then, may I have the third, sir? Professor M. Jawar is a well-known personality. He is a professor, unit head, and is at the same Institute of Neurology, Madras Medical College in RG3H, Chennai. And I am also fond of hearing his discussions. We have heard him at some other platforms in Tamil Nadu and IN also. So Professor Jawar would be taking us into the intricacies of this case, how the storm has occurred and what was the kind of exact storm and which is that Winter is talking about. So
Thank you.
and I will request this time Dr. Lakshmi to put some final comments also. So with this brief introduction of the various discussions, I request Dr. Jawahar to take it forward. And I once again want to thank Team Intas and all the delegates. I really want to convey once again very, very bright and prosperous, wonderful new year to each and everyone. Thank you very much. Professor Jawar, please.
Thank you, sir. On behalf of Madras Medical College Institute of Neurology, I welcome all the viewers and delegates for the interesting case discussion. This case is actually very rare presentation. We have never seen such a case, and because of the rarity, we want to present and discuss how we can able to arrive at the diagnosis and what are the investigations we have to do. For that purpose only, I am presenting this case, sir. So, shall I, Dr. Aishwarya, can you start the presentation?
Yes, sir. So, shall I start, sir?
Yes, yes.
Good evening to one and all. Prior to starting the case session, I would like to thank at the onset our director, Professor R. Lakshmi Narasimhan sir, for giving an opportunity to present a case in this esteemed forum. I would also like to thank our unit chief, Professor Dr. Jawahar sir, as well as our assistant professor, Dr. Krishna Kumar sir, for being the guiding forces in this presentation. So coming to the case, we present a case of a 51-year-old male patient, Mr. K, who is a resident of Ranipet in Chennai. He's a retired driver and is a right-handed person. Presenting complaints were recurrent episodes of fainting during standing since 1 month and recurrent episodes of loose stool since 1 month. History of presenting illness. Patient was apparently normal 1 month back when he developed fever, which was intermittent, low grade, lasted for 5 days, subsiding with antipyretics. 2 days after fever settled, he developed complaints of loose stools, 10 to 12 episodes per day, watery, large volume, with no blood or mucus in stools and no pain during defecation. There was no history of any nocturnal diarrhea or fecal incontinence. For the above symptoms, patient was admitted to an outside hospital and started on IV medications with IV fluids. On the 4th day of loose stools, he developed towards the end of micturition while standing 2 episodes of loss of consciousness lasting for a minute, each time preceded by a sense of impending fainting with blackening of vision in both eyes, so that he used to support himself against the wall with subsequent transient unconsciousness followed by spontaneous regain of consciousness. There was no history of any associated palpitation or diaphoresis prior to or during the episodes. After these episodes in bathroom, he was able to ambulate by self to his hospital bed. Since then, he has experienced no such symptoms as patient voids by sitting on the bedpan. Post these 2 episodes of transient loss of consciousness during micturition, patients started developing complaints of whenever standing up from the bed after 2 minutes, sudden onset blurring of vision of both eyes with zigzag lines in his field of vision, followed by spinning sensation with blackening of vision, followed by loss of consciousness lasting for a minute, which is followed by spontaneous regain of consciousness with a diffuse aching pain over the nape of neck and bilateral shoulder lasting for 10 minutes. There was no history of any associated diaphoresis or palpitation prior to or during the episodes. No history of any exertional activities prior to these episodes. No history of any tongue bite, frothing at mouth, lip smacking, eye flutterings, involuntary jerky limb movements, abnormal posturing of limbs, or urinary or fecal incontinence during these episodes. No history of sustained confusion post these episodes, and he's able to recollect what has happened to him. No history of oral fullness or tinnitus or vertiginous sensation prior to or during the episodes. Post these episodes of postural fainting, once he lies down, he's able to get up after a minute and ambulate by self for 2 to 3 minutes, followed by again a feeling of giddiness requiring need to rest, so much so that he has been mostly bedbound for the last 1 month. Frequency of these attacks is static throughout the course of 1 month. There was no history of any urinary history. Frequency, feeling of incomplete evacuation or nocturia. Patient has history of nausea for 1 month, which is more for solids than liquids. There was no history of any associated vomiting or pain abdomen. Associated decreased intake of food was present due to nausea, leading to weight loss of 7 to 8 kg in last 1 month. Appetite is decreased due to nausea, with no complaints of early satiety, postprandial blotting, postprandial angina, or postprandial episodic fainting. No history of difficulty in swallowing or nasal regurgitation or coughing during feeding. No history of any slurring of speech. History of 1 episode of involuntary ejaculation was present in last 1 month. There was no history of any retrograde ejaculation or erectile dysfunction with normal early morning penile tumescence. There was no history of altered libido. No history of dream enacting behavior during sleep or apneic spells during sleep or disturbed nighttime sleep. No history of diaphoresis or anhidrosis. No history of trophic skin changes, frequent goosebumps on skin, lymph ulcers, or facial flushing. There was no history of nail discoloration or hair loss. No history of dryness of eyes or foreign body sensation in eyes. No history of dryness of mouth or excessive drooling of saliva. No history of persistent blurring of vision or photophobia. No history of any limb weakness, no history of stiffness of limbs, no history of cotton wool sensation, numbness, tingling, burning pain in hands or feet. Patient is able to feel the clothes worn by him, able to appreciate hot and cold water equally all over the body. No history of radiating pain or electric shock-like sensation of bending forwards. No history of girdle-like sensation in trunk. No history of any slowness of activities. No history of tremulousness of limbs, and no history of altered or decreased sense of smell. There was no history of unsteadiness while walking or difficulty insinuating the feet into slippers or smearing of food on face while feeding. There was no history of headache, altered sensorial memory or behavioral disturbances or hallucinations. No history of drooping of lids or double vision. No history of inappropriate laughter or crying. No history of recent trauma. No history of fever, joint pain, rashes, or any recurrent oral ulcers. No history of exertional dyspnea or swelling of feet or easy fatigability. Coming to past history, there was no significant past history. Personal history, patient was on a mixed diet, bowel and bladder habits as mentioned before. The sleep was normal, appetite was reduced due to nausea. He's a non-smoker, non-alcoholic with no history of high-risk sexual behavior. Family history, there is no history suggesting a similar illness in his parents or his siblings or in his parents' family. And there was no history of sudden cardiac deaths in the family. So this is a video of the episode.
Can you explain, Aishwarya, what has happened during that episode?
So during this episode, sir, first patient was initially complaining of a sensation of impending faintness, sir, followed by blackening of vision in both eyes, sir, with zigzag lines in his field of vision, followed by a transient loss of consciousness lasting for a minute, after which he was able to get up and ambulate for a few minutes, sir. So it started initially as a pre-syncope, sir, followed by a syncope, sir.
So it is not associated with any limb jerks?
No,
Or
sir, there was no
seizure?
history. No, sir, there was no history suggestive of any seizure, sir. There was no history of any tongue bite, no urinary or fecal incontinence, no uprolling of eyes, sir, and no involuntary limb movements.
He is able to recollect the events clearly?
Yes, sir. There was no history of any post episode. There was no sustained confusion, sir.
Okay. Right, proceed.
So coming to a summary, 51-year-old male with nil comorbidities presented with sudden onset, non-progressive, subacute neurological illness of 1 month duration in the form of an acute febrile illness with persistent loose stools and nausea, followed by 2 episodes of transient fainting with loss of consciousness during nutrition, followed by episodic postural fainting with loss of consciousness lasting for a minute, with no involuntary limb movements, tongue bite, significant postictal confusion, with 1 episode of involuntary ejaculation, no upper or lower limb weakness, and with no history of higher mental functions, sensory, cerebellar, extrapyramidal disturbances without any history of similar illness in family members. So shall I continue to the examination, sir?
Shall we go for examination, sir?
Yes, please go.
Yes, examine.
On examination, patient is moderately built and nourished. He's conscious, cooperative, oriented in time, place, and person. Pulse rate was 92 beats per minute, was regular. Blood pressure was 110 by 74 millimeter of mercury in supine position. Orthostatic vitals will be coming later, sir, under autonomic system examination. Respiratory rate was 16 per minute. Saturation was 99% in room air. Patient was afebrile. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Oral cavity was normal. Tonsils were normal. Skin, there was no rash or ulcers. There was no hypo or hyperpigmented patch. There was no purpura. There was no neurocutaneous markers and no skeletal abnormalities or facial dysmorphism. And there was no peripheral nerve thickening. Higher mental functions, patient was conscious, oriented to time, place, and person. His attention was normal. Recent and remote memory was intact. Language and speech were normal. MMSE was 28 out of 30 and lobar functions were normal. Coming to cranial nerve examination, cranial nerve 1, sense of smell was present bilaterally. Cranial nerve 2, visual acuity was 20 by 70 bilaterally. There was no visual field defect on confrontation testing. Color vision was normal and fundus was normal. Cranial nerve 3, 4, 6, pupil size bilaterally was 1.5 millimeter. Both direct and indirect light reflex was present but sluggish. Accommodation reflex was present bilaterally. Extraocular movements were normal bilaterally. There was no ptosis, no nystagmus. Saccades and pursuits were normal. Coming to cranial nerve 5, sensory facial sensations over V1, V2, V3 areas were normal bilaterally. There was no weakness of masticatory muscles. Reflexes, corneal and conjunctival were present bilaterally. Coming to cranial nerve 7, forced eye closure, blowing of cheek, whistling were normal. There was no deviation of angle of mouth and taste was intact. Cranial nerve 8, Rene's test, air conduction was more than bone conduction bilaterally. Weber was not lateralized. Cranial 9 and 10, you will have palatal arches and movements. There was no palatal loop. Palatal movements were equal bilaterally and gag was present bilaterally. Cranial 11, shrugging of the shoulders and turning the head to side by side were normal. Coming to cranial 12, there was no weakness of tongue, there was no deviation of tongue, no wasting and no fasciculations in the tongue. Coming to motor system examination, there was no wasting of muscles. Tone was normal in all 4 limbs. Coming to power examination, there was no neck muscle weakness. Power in upper limb across the shoulder joint, the elbow joint, and the wrist joint was 5/5. This hand grip was 100% bilaterally. There was no truncal muscle weakness. Again, power in the lower limb across the hip joint, the knee joint, and the ankle joint was 5/5. Coming to the superficial reflexes, corneal, conjunctival, gag, superficial abdominal, cremastic, and bulbocavernous reflexes were present. Plantar was flexor bilaterally. Coming to deep tendon reflexes. Deep tendon reflexes on the right side, his biceps was 2+. On the left side, it was 1+. Supinator was 1+ bilaterally. Triceps was 2+ bilaterally. Knee, medial hamstring, and ankle were 1+ bilaterally. Sensory system examination, touch, pain, and temperature was normal. Timed vibration was normal. Spinal vibration was normal. Joint position sense was normal. Romberg's test was negative. Cerebellar examination, there was no scanning dysarthria, no nystagmus or head titubation, no rebound phenomena, intentional tremors. Upper and lower limb coordination tests were normal. Extrapyramidal system examination was normal. Signs of meningeal irritation were absent. Skull and spine were normal with no vertebral tenderness. Coming to the autonomic nervous system examination, his heart rate on supine was 92 per minute regular. On sitting, it was 96 per minute regular. Blood pressure was 114/74 millimeter of mercury supine. On sitting, there was a drop to 90/54 millimeter of mercury. Active standing orthostatic test, patient was able to stand for only 30 to 50 seconds on posture change from supine position. There was no resting tachycardia. Orthostatic hypotension was present with a fall in systolic BP of 24 millimeter of mercury and diastolic BP of 20 millimeter of mercury. There was no nocturnal supine hypertension. Nocturnal BP readings were in the range of 130 to 80 millimeter of mercury. Pupils bilaterally were 1.5 millimeters, sluggishly reactive to light. There was no ptosis. Cerebrospinal reflex was absent bilateral. There was no hyperhidrosis or anhidrosis. Mental arrhythmic test was abnormal. In supine position, pre-test, the blood pressure was 114 to 78 millimeter of mercury. In post-test, it was 120 to 80 millimeter of mercury. So there was no increase in diastolic BP pre and post-test. Cold pressure test was abnormal. Supine position, the pre-test value was 124/84 millimeter of mercury. In post-test value, the was 126/84 millimeter of mercury. And there was no rise in systolic BP pre and post-test. Sustained hand grip test was normal actually. Pre-test, the supine BP was 114/78. Post-test was 124/86. There was no trophic skin changes, ulcers, or skin discoloration. Peripheral pulses were palpable, bilaterally equal. This was the ECG of the patient. In lead 2, there is no sinus arrhythmia. This was the autonomic function testing which was done for the patient. So the heart rate variability to deep breathing, the normal reference values should be more than 15 per minute. Our patient did not have any heart rate variability, it was only 2 per minute. The expiratory to inspiratory ratio, the normal reference should be more than 1.2. For our patient, it was below that, was 1. Valsalva ratio, the reference value is more than 1.45. For our patient, the Valsalva ratio is less, it was 1.1. The orthostatic tilt test, the heart rate should be more than 10 per minute. For our patient, it was 13 per minute, and 30:15 ratio should be more than 1.04. For our patient, it was 1.1. This was a sympathetic skin response test which was done for the patient. In upper limb, actually, biphasic and triphasic waves are present, while in the lower limb, bilaterally, no waveform was obtained. Now here, only the absence of the response is considered pathological and not the absolute values. Coming to cardiovascular examination, S1, S2 was heard, there was no murmur. Respiratory system examination was normal with normal vesicular breath sounds and no added sounds. And abdominal examination was normal with no organomegaly and bowel sounds were heard. Coming to the summary, So it's a 51-year-old male patient with nil comorbidities presented with sudden onset, non-progressive subacute neurological illness of 1 month duration in the form of an acute febrile illness with persistent gastroenteritis as loose stools and nausea, followed by 2 episodes of transient fainting during micturition, followed by episodic postural fainting with loss of consciousness lasting for a few minutes, with no involuntary limb movements, tongue bite, significant postictal confusion, no upper or lower limb weakness, and with no history of higher mental function, sensory, cerebellar, extrapyramidal disturbances, without any history of similar illness in the family members. The summary of the examination, he had autonomic dysfunction with orthostatic hypotension, abnormal mental arrhythmic and cold pressure test, which suggests a sympathetic dysfunction, with 1.5 millimeter pupil size bilaterally with sluggishly reactive pupils, which again suggests a sympathetic dysfunction, with no cognitive, motor, sensory, cranial nerve, extrapyramidal or cerebellar involvement.
Okay, thank you very much, Dr. Aishwarya.
Okay, sir.
Yes, continue. Yes. Now, I think the discussion can be taken over by. Yeah, you're not finished the investigation.
Yes, sir. Shall I continue with the investigation, sir?
Yeah, continue.
So the investigations, complete blood count and LFT was normal. RFT showed a mild hyponatremia and hypokalemia with an SIADH picture. Viral markers were negative. CSF glucose was 71. Protein was marginally elevated at 53. Total counts were 10 with predominant lymphocytes. It was negative for malignant cells. FBS, PPBS, and HbA1c were normal. Y2 and B12 levels and folic acid levels were normal. TSH, cortisol, ACTH, and urine 5-hydroxy-indole acid levels were normal. Stool culture and sensitivity initially was reported as query Salmonella typhi. Repeat stool culture and sensitivity after 2 weeks, there was no enteric pathogen seen. Widal test was negative. Heavy metal screen was negative. Serum protein electrophoresis, there was no MBAN. Urine Benson's protein was negative. OGD-scopy and colonoscopy showed a normal mucosal study. Anterior abdominal fat pad biopsy was negative for amyloidosis. Cardiac evaluation with ECG, echo, Holter monitoring was normal. Paraneoplastic autoantibody panel done was negative. All body PET-CT was normal with no evidence of altered metabolic uptake. CV Doppler was normal. MRI brain was normal. EEG was normal. NCS and repetitive nerve stimulation test was normal. EMG was normal. Ultrasound abdomen was normal. Prostate was normal with no evidence of any hydroureteral nephrosis. Uroflowmetry could not be done as patient was unable to stand. Vasculitis panel, ANA, ENA ANCA was negative. ANA HEP2 panel was negative. ANA 3 panel showed PMSCL and anti-KU antibody positive. Anti-SSA and anti-SSB antibodies were negative. Schirmer's test 1 was bilaterally positive with 2 millimeter and 3 millimeter per 5 minutes.
So, finished?
Yes, sir.
So it is a purely a case of autonomic dysfunction in the form of postural hypotension and a persistent diarrhea with some positive investigatory findings. So these things I
Yes,
will
sir.
call upon Dr. Krishna Kumar, our
Thank you,
assistant
sir.
professor, to discuss approach and how to approach the autonomic dysfunction cases and discuss this case.
Thank you, sir. Respected director, respected chairperson, respected professors, assistant professors, and all, a warm good evening. At an outset, I would like to thank our Professor Ellen sir for providing this opportunity. I would thank Professor Jawahar sir for providing me this opportunity. Coming to this case, this case has predominant clinical features suggestive of autonomic nervous system involvement in the form of pupilomotor involvement, cardiovascular autonomic dysfunction, genitourinary autonomic dysfunction, gastrointestinal autonomic dysfunction. Further, it says there is a decreased sympathetic function in the form of pupilomotor, cardiovascular, and genitourinary, and increased parasympathetic function in the form of diarrhea. With this, the following autonomic tests suggest, namely the sustained hand grip, cold pressure test, mental arithmetic test, suggests that the sympathetic dysfunction is there. With heart rate response to deep breathing, it suggests that there is parasympathetic involvement is there. With Valsalva suggesting both sympathetic and parasympathetic involvement. HR tilt test suggesting parasympathetic cardiovagal impairment is there. So with this test and then with the specific individual investigations, with a pure autonomic involvement in this case, we'd like to consider an autonomic dysfunction. Either it could be central or peripheral. In view of no non-track signs, no extrapyramidal signs, no higher mental function involvement, a probable central autonomic dysfunction is less likely. Even there is no involvement of peripheral nervous system, so peripheral autonomic dysfunction with PNS is also less likely. It's only a pure peripheral autonomic dysfunction presenting as an orthostatic hypotension with a pupillary abnormality, ejaculatory dysfunction, and with diarrhea. Combining all these symptomatology, the following possibilities can be considered. Since patient initially presented with a history of fever, following which he developed these problems, a likely post-infectious GBS variant possibility can be considered as a first possibility. The second possibility entertained can be connective tissue disorder, as patient has features of connective tissue antibody positive, namely Q antibody was positive, SEL antibody was positive. Also, Sherman test was positive. So, connective tissue disorder as a possible etiology can also be considered. A third possibility of autoimmune autonomic ganglionopathy can also be considered. That is ganglionic nicotinic acetylcholine receptor antibody against autonomic ganglia can also be considered. But we could not do this test as this test is not available with our setup. The fourth possibility we considered was a celiac disease, which also presents with a GE manifestation, with a rare manifestation of autonomic dysfunction it can present with. The last possibility that we considered was a pure autonomic failure, that is alpha-synuclein deposits in the autonomic ganglia. Maybe in future patient might develop a multisystem atrophy or any Parkinson plus syndrome. This may be initial manifestation. So these are all the possibilities that we considered. The first possibility is post-infectious GBS variant. Second possibility we entertained was connective tissue disorder. The third was autoimmune autonomic ganglionopathy. Fourth was celiac disease. And fifth was pure autonomic failure that we considered.
Yes, Krishna Kumar, yes.
This once again only repeating the same investigations. The investigations as already projected by Dr. Aishwarya. I don't want to repeat this.
The positive findings, you just again you insist on the positive findings, investigation findings.
Yeah, positive investigation finding is that the vasculitis panel was positive. That is the ANA3 panel, PM-SCL and Q antibody was positive. And Sherman test was positive, depicting probable Jogren could be there. Then we have also sent a lip biopsy. Probably it's awaiting report.
Okay.
The other specific investigations were negative. Even paraneoplastic antibody panel we did, but that came to be negative. And then PET scan we did, but there was no evidence for any abnormal intake. And even serum electrophoresis was normal. Anterior abnormal fat pad biopsy was negative for amyloid. B12, thyroid profile, blood sugar were all normal. Serum cortisol level was normal. Viral markers was negative. A metal screening also was negative. Sir, shall I proceed with the treatment or?
Yeah, whatever treatment, what treatment you have given and what is the response, you please tell.
Yeah, the patient was initially treated elsewhere, where they have started the patient on IV methylprednisolone pulse followed by oral steroids they have given, but there was no significant improvement for the same. So we actually, patient when he came to us was already taken methylprednisolone elsewhere. So we started the patient on IVIG 0.4 gram per kg daily for 5 days. Following which also patient was not having very significant improvement, was not there. So we considered the possibility of starting a oral immunosuppressants, namely the azathioprine along with oral steroids. As a patient also had a connective tissue disorder, antibody panel was positive. So we thought that we could introduce immunosuppressants along with fludrocortisone and loperamide for symptomatic management of blood pressure and loose stools. And over the course of treatment, patient improved as far as the postural syncopal attacks is concerned, is significantly improved for the same, and is able to walk for a longer distance without difficulty. He was able to stand even for 5 minutes, even without difficulty. But still, he has some amount of gastrointestinal symptoms are persisting. Initially, he had at least 10 episodes of loose stools. Now he's at least having 2 to 3 episodes per day. So probably patient is in the road to improvement. That's what we conclude. And then we're awaiting report for the connective tissue panel also.
Okay. Okay. So you think it could be a post-infectious autoimmune failure because as a GBS, atypical GBS manifestation, first, as a first possibility.
Yes, sir.
Or it could be a autoimmune autonomic failure that may be due to this nicotinic acetylcholine, ganglionic acetylcholine receptor antibody activity,
Yes,
that we have not done it. And third, because of the presence of this connective tissue disorders like PMCSCL positive and ANA positive, all these things, and Skirmer test doubtfully positive. So you think a background Sjogren syndrome or SLE or the systemic sclerosis possibly presenting as autonomic failure. That is also a possibility.
Yes, sir.
And fourth, actually celiac disease, a very rare manifestation of this celiac disease, usually present with the peripheral neuropathy, painful peripheral neuropathy, but this patient atypically can present as a pure autonomic dysfunction, which is very rare. But anyhow, we have to do a wellness biopsy in this patient.
Yes,
And
sir.
finally, the pure autonomic failure. So pure autonomic failure, what is the, actually it is due to, what is the pathology there? You are not told about the pathology. What is pure autonomic
Probably an
failure?
alpha-synuclein deposits over the autonomic ganglia producing the problem.
So can it transform to any other disease or just remain as a pure autonomic failure? This.
It can also transform to multi-system atrophy.
Yes. So it can go for a transformation like MSA and Parkinsonism and DLB. Any type it can transform.
Yes,
But most probably the MSA, the where the patient will have a significant autonomic dysfunction. So anyhow, with available investigations, only we can able to arrive at this first 3 diagnosis. All the other things we had to prove. Shall I ask Mrs. Haley to present my slides? I have sent the slide, my slide, 3 slides only by email to your email. Can you share the slides, Mrs. Haley?
Yes, sir, just a minute.
Yeah. So the problem in this case, actually, we have seen so many cases of autonomic dysfunction in the background of small fiber neuropathy, like alcoholic neuropathy, diabetic neuropathy, or in the presence of Parkinsonism, that is the MSA. So this type of cases we have frequently seen, but this is the first case where we have seen a pure autonomic dysfunction without any associated disease. That is the very importance of this case for which we have presented. Have you shared my slide?
Sir, Krishna Kumar sir needs to unshare his screen.
Yeah, I'll
I'm
stop.
able to share. Yeah.
Oh, okay. Next slide. Okay. See, actually, whenever we deal a case of pure autonomic dysfunction, first in the history taking, we have to give certain importance regarding the onset of the disease, whether it is acute onset or a gradual insidious onset, or it is present since from birth. So it definitely gives a clue to the diagnosis of the case. So in this case, purely is an acute onset after an episode of fever. The patient has presented with the pure autonomic dysfunction in the form of postural hypotension and diarrhea. So it could be due to because of the molecular mimicry, the patient can have autoimmune phenomena causing the problem in the ganglia, sympathetic ganglia and parasympathetic ganglia, presenting as an autonomic dysfunction. So that is the possible in this case. And we have to ask the next this thing: how rapidly did they develop? How rapidity with which the autonomic dysfunction progresses? Usually, this type of rapid progression can happen either in a paraneoplastic autonomic failure, or it can be due to an autoimmune failure, autoimmune autonomic failure. Also, you can have a very rapid progression. And you have to ask whether the patient is having an associated symptoms like a small fiber neuropathy, painful and pricking pain, and or any Parkinsonism is associated, or is there any cerebellar ataxia, which shows that whether the patient is having an MSA with the autonomic manifestation or a small fiber neuropathy with autonomic manifestation. And at the same time, we have to ask for any medication which has been started at the time, because many of the medications available over the counter or prescribed by the doctor has got some autonomic dysfunction as a side effect. So this, we have to rule out medication-induced autonomic dysfunction also. So I will deal the medications later. And any antecedent viral infection in this patient is a viral infection probably, or any toxin exposure, which I am going to deal in the next slides. Whether the patient is improving or worsening during the course of illness. Next slide. So when you come to the acute onset autonomic failure, first thing is drugs. So drugs, many drugs we are commonly using like SSRI and SNRI. These things, they will increase the sweating in the patient. So patient will come to increase the sweating means you need not go for an autonomic dysfunction or something like that. You have to ask for the SSRI, SNRI intake. At the same time, this topiramate and acetazolamide, both are carbonic anhydrase inhibitors. They can reduce the sweating. So patient can present with hypohidrosis and sometimes anhidrosis also. So we have to take care of these medications. And regarding the postural hypotension, we already know that beta blockers, vasodilators, and other centrally acting drugs like clonidine, methyldopa, reserpine, MOB inhibitors, all can produce a postural hypotension. And if the patient is receiving anticholinergic or a cholinergic, patient can present with either a constipation or diarrhea. And whether you have to ask whether patient had received any chemotherapy drugs like vincristine and blastin, which can present with an autonomic neuropathy, small fiber autonomic neuropathy. So we have to ask for the chemotherapeutic history. And regarding the toxins, I already know that alcohol is a number one toxin that can produce a small fiber neuropathy along with autonomic dysfunction. And other metal poisoning like arsenic, thallium, mercury, all these things can produce a small fiber neuropathy along with autonomic dysfunction. Organophosphorus compounds also can produce autonomic dysfunction in the form of persistent diarrhea because of the increased cholinergic activity. The other infections also, we have to take care that whether if the patient suffers from botulism, the patient can have a hypercholinergic, this hypocholinergic activity. Patient can have a constipation and pupillary dilatation, all these things. And other HIV, tetanus, Lyme's disease, Chagas, all these infection can produce an autonomic neuropathy. So we have to search for the cause for the infections, also if the patient having any fever or other systemic illness. And you know very well that the GBS as an atypical manifestation, pure autonomic dysfunction can happen in a GBS. Probably in this case, doubtful whether this patient has a atypical GBS in the form of this CSF protein is 53, slightly increased, and the deep tendon reflexes slightly depressed in many areas except the triceps. So it could be an atypical manifestation of GBS. But many cases of GBS, in the case reports, what they are told, it is not the patient will not present like a pure autonomic dysfunction. Patient can have mild motor weakness, sometimes sensory paresthesia. All these things can coexist along with the autonomic dysfunction. So, and other things, traumatic paraplegia, say, for example, if the any cord compression above T6 level can produce autonomic dysfunction. And paraneoplastic, especially the lung carcinoma and pancreatic carcinoma can present with the autonomic dysfunction either as an acute or chronic presentation. Porphyria, you know very well that it can present with pure motor polyneuropathy, but autonomic dysfunction it can cause very rarely. And in this case, because of the presence of PMSCL positivity and ANA3 positivity and Schirmer test positivity, the possible background connectivity disorder in the form of SLE or Sjogren's disease has to be ruled out. We are planning for a liver biopsy in this patient. Systemic sclerosis also. Celiac disease, still the patient, even after treatment, the patient is having continuous diarrhea in the form of at least 3 episodes per day. So we want to take a villus biopsy to rule out a celiac disease in this patient because these anti-gliadin antibodies can interact with the autonomic ganglia that it can produce autonomic dysfunction. And rheumatoid arthritis also can present with autonomic dysfunction. Next slide, madam. And if the autonomic dysfunction happens very slowly and gradually occurring in a chronic period, means especially in diabetes, very commonly we are seeing long-standing diabetic people, they have autonomic neuropathy, uremic and hepatic failure. All this can produce autonomic dysfunction. And inherited diseases, if that autonomic dysfunction happens from childhood, then inherited diseases like familial dysautonomia, that is hereditary sensory autonomic neuropathy type 3, Rayleigh, or dopamine beta hydroxylase deficiency. These two are autosomal recessively inherited disorders where the patient can present with autonomic dysfunction and insensitivity to the pain and temperature. And other small fiber inherited neuropathies like Fabry's, Tangiers, and familial amyloidosis all can present with amyloidic autonomic dysfunction. So if the patient present with a associated small fiber neuropathy, you have to rule out all these causes. If it is a chronic problem, if it is an acute problem, I as I told you have to rule out the toxins and other drugs and everything. And other chronic diseases as MSA, multiple sclerosis, posterior fossa tumors and the spinal cord tumors, by compressing this autonomic pathway, they can produce autonomic dysfunction. So these are all the background diseases we have to search for in any case of autonomic dysfunction, especially in this case because it's an acute onset preceded by a fever. So we could only provide a differential diagnosis of already discussed by Krishna Kumar. Either it could be a GBS atypical presentation, or it could be a autonomic autoimmune failure, or it could be a connective tissue disorder presenting as autonomic dysfunction, which we have to complete the investigation and will come forward with the definite diagnosis in this patient. Sir, is there any question?
For it's a wonderful presentation of isolated autonomic dysfunction, and for the sake of there are a few questions in the question box, and Dr. Atif Kausa he has suggested that hypoadrenalism should also be guessed at a lower down in the order. That's
which one, sir?
Hypoadrenalism.
And the lower down the order.
Deficiency because of the postural hypotension and
yes.
This will be considered at a lower down in the order. Okay.
Yes, sir. Yes,
somebody suggested, can it be DPPX, which is one of the autoimmune, but the DPPX was negative, which we have worked out in the autoimmune panel. DPPX encephalitis was suggested by somebody, which we have worked up, and it was negative.
It was negative. Yes.
And the third question, in the autoimmune panel, such as subacute onset, anti-LGI1 encephalitis with the diarrhea, hyponatremia, although facial dystonic seizures are absent, should we consider that also? Yes, you can consider, but generally, predominantly motor manifestations will be there in LGI, and the psychiatric hallucinations and all those cortical things would be there. Very pure autonomic things we have not seen so far.
But in the case of limbic encephalitis, we used to have autonomic dysfunction along with other manifestations of psychiatric and memory disturbances and all. So that is also limbic encephalitis that can
Yeah.
present with autonomic dysfunction.
Is the neck pain mentioned in the patient? Is it like a coat hanger sign seen in MSA?
Actually, coat hanger sign is a sign of hypotension. Hypotension, where the coat hanger sign, the patient will have a neck pain and the shoulder pain, which is the classical presentation of a postural hypotension. So it can happen in any case where the patient will present with the postural hypertension. It is not exclusive of MSA or something like that.
So these are the few questions.
Mm.
And regarding the storm in the winter,
Yes, sir.
and in fact, in any autonomic, see, we just, for sake of creating interest in all of you, that in any autonomic nervous system case, you should be very careful, because the autonomic storm is the most dreaded complication of any autonomic nervous system. Even in GBS, you know, what
Mm.
kills the patient most often is the autonomic storm. So the autonomic storm can be part of the sometimes brain injury, sometimes in GBS, sometimes can be part of the spinal injury, as Professor Jawahar said, or it can be part sometimes in encephalitis can also produce autonomic storm. So in fact, when this patient was, that is why you require continuous monitoring of these patients on all the autonomic parameters. Secondly, for the sake of postgraduates, you should, two things you remember. In any case, you decide whether it is sympathetic or parasympathetic. In sympathetic, then decide whether the symptoms are noradrenergic or adrenergic, increase or decrease. Same thing with the parasympathetic, you decide the cholinergic, whether it's cranial or sacral, increase or decrease. So in these four subgroups, you will get a combination. Similarly, in the investigations also, you have afferent efferent limb of sympathetic. Similarly, afferent limb and efferent limb of parasympathetic. And otherwise, look for this, the pseudomotor, the pupilomotor, the cardiovasomotor, and the respiromotor, as well as the gastrointestinal and urogenital. So you system-wise also you can approach. So these are all the few. We presented this case for its uniqueness, isolated autonomic, and it is generally in exam, invariably there will be some questions on autonomic nervous system, whether you have done autonomic function tests and all these things. So to just go through this academic exercise of the, I should thank Dr. Jawahar for bringing out this wonderful case for this forum. Any other comments from anybody, sir?
Exactly what you said. I mean, I would have expected some details of autonomic function tests done on this patient bedside and others, like cardiovagal heart rate function, Valsalva ratio, heart rate response to standing, or laboratory indices of adrenergic function, or sustained hand grip, or baroreceptor testing, blood pressure, tilt test testing, pseudomotor, thermoregulatory, all those tests that we ask in exam, sympathetic skin response, now conduction studies, and even transesophageal echo. Sometimes in a case of atrial myxoma, you get postural hypotension like this. So, I mean, from various angles, this case is very interesting. Before calling it pure autonomic failure, we have to investigate from different angles. At the same time, we have to demonstrate which are the autonomic dysfunctions prevalent in this particular case. The history, if you see, patient had 2 episodes of passing out while standing or doing micturition. From that, straightway we reach to the conclusion of autonomic dysfunction. I think before that, in a normal exam setting, this is all,
1 minute.
but we-
Excuse. Following the 2 episodes, every time when he stands, within 1 or 2 minutes, he is having profound postural hypotension and he is falling. So he was bedridden for past 1 month, and after treatment only now he is able to walk to little bit.
Oh, exactly. But when we discuss for the neuro residents across India, I mean, causes of passing out or drop attacks and things like that. And then gradually, if we unfold, it becomes little more educating. Perfect, right? But we had enough time, and I thought we can discuss, as Dr. Lakshmi brought out the point, various autonomic nerve function tests or various differential clinical diagnoses. This is a wonderful case. You have done a great job, and in all these 28 episodes, I don't think atomic dysfunction was ever discussed. So this was very relevant. I'm just telling that we could, for the students, that they have to read up all these things, how you come for the, come with the different clinical differential diagnosis, different autonomic nerve tests, which we mentioned, and then stage-wise investigating. So what is the ultimate take, Dr. Jawar? What do you think this is most likely?
So most likely it could be because the patient responded to IVIG after a delay of 1 week. Probably this could be a post-infectious GBS atypical presentation with the pure autonomic problem, because the CSF protein is elevated and some jerks, tendon jerks are depressed. And there are some evidence for connective tissue for this thing also, this system is called PMSCL and ANA positivity and Skirmer's test. So which we have to rule out whether the background any connective tissue disorder is there or not in this patient. So we are at present.
Response test was done.
Yes,
Sympathetic in response test or some. How do you prove or disprove this particular thing?
It's actually this. Regarding proving the case, so proving the etiology for this case. So one is for autoimmune autonomic failure, we have to do the antibody test, that is nicotinic ganglionic acetylcholine receptor antibody. If it is positive, it is definite that it's an autoimmune phenomena where because of the autoimmune problem, that autoimmune failure has happened. So it needs a long-term immunosuppression with steroids treatment as a treatment. But this post-infectious GBS and all, once we give IVIG, the patient will improve, and there is no need for any further treatment. Patient will automatically improve. And background connective tissue disorder also requires a long-term immunosuppressant and steroids. So we have to confirm by doing further tests in this patient. For celiac disease also, because the patient having a persistent diarrhea of 2 to 3 episodes, we want to do a villus biopsy to look for anti-gliadin antibodies. If it is positive, then definitely it is also is a confirmatory thing for celiac disease also. So all these things we are working up this patient before completing the investigation. We presented because of the
short notice. The case is in the middle of the working. Because of the short notice, we didn't want a break in because we have not defaulted even once in these 2.5 years. So I thought I had to step in, because I asked for a few other colleges. They were not in a position, because the World Stroke Day is also tomorrow. So they were all busy with their CMEs and other things. So I thought I didn't want to disappoint people. I thought this is a fairly reasonably good exercise for the students. So that's why we chose this case.
It is a reasonably good exercise. They are given a lot of thought processes. But at the same time, I would wish that when we do next CME after a month, kindly give a short follow-up in a couple of minutes.
Sure, sir. Sure.
Definitely.
Thank you.
It's a very exciting and very interesting situation. And my compliments to whole team, particularly Dr. Aishwarya, Dr. Krishna Kumar, and of course, Professor Jawar, for bringing down salient points and the way forward. Thank you very much. Dr. Lakshmi, if you have any closing comments, it's only 9 o'clock, so I thought we should discuss a little more. That's why I brought up some points.
No. Since there is this case is purely autonomic and no other signs. But one thing, as you rightly said, that you have to keep in mind on a follow-up of such patients, because they can evolve into any other illness at a later point of time. So at this point of time, we are thinking that this is autonomic, but it can always it can still turn out to be in synucleopathies. because the initial manifestation of deposition of alpha-synuclein in the autonomic ganglia can present this. Later on, the deposition can start elsewhere. So, you would have seen that in Parkinson's also, the Lewy bodies were demonstrated in the parotid. You don't have to demonstrate a Lewy body in the brain. The parotid biopsy has demonstrated presence of Lewy bodies. So we really do not know whether it is similarly gastrointestinal rectal biopsy have demonstrated Lewy bodies in case of Parkinson's. So we probably this could again turn out to be alpha-synucleinopathy at a later point of time, and even a biopsy from one of the autonomic ganglia can look for alpha-synuclein, can become positive also. So we just keep our fingers crossed. We'll give an update after all the workup. We'll give an update during one of our next episodes, sir.
Yeah, so that was exactly my point. How do you prove the diagnosis? So one by one, exclusion and inclusion investigation should be done, including biopsies of the relevant places one by one, even endoscopy if it comes to upper and lower GI. Maybe PET scan at some stage, PET CT body. Yeah, and PET MRI with that.
Yes, sir.
PET CT
In
body.
this patient, excuse me, in this patient, the olfactory functions are absolutely normal. But anyhow, we are planning to follow up the patient, whether the patient will develop Parkinsonism in the later date. And we want to do a perianal EMG also to look for any early denervation changes.
At this picture, it seems like pure autonomic dysfunction. So from that point of view, it becomes extremely unusual and rare case, and we hope we'll learn more after the investigation. My compliments to the whole team once again, and also special thanks
Thank you, sir.
for accepting it a very, very short time. And thanks to Dr. Lakshmi for pushing this up. Thank you very much.
Thank you very much, sir. Thank you.
Thank you, sir.
Thank you, sir. We have come to an end to episode 28 of Secrets of Neurology, the longest running webinar series in India. I, Heli Gadani, would like to thank all the delegates for the continuous and consistent support in terms of their presence. Today, we witnessed a very insightful and unique case, A Storm in Winter, and I'm sure all the delegates would have learned a great deal out of the same. I'm thankful to Dr. Jawahar sir, Dr. Krishna Kumar sir, and Dr. Aishwarya ma'am for presenting this case. Last but not the least, I'm also thankful to the course directors, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, for giving us an opportunity to be associated with this wonderful scientific platform. With this,